assistant is not going to make it today. Does anybody want to be the model? And does anybody want to video what we're doing?
I'm doing it right now, so don't step in front.
Well, but you have to have permission from the model. You going to be the model? Yeah. Can she have your permission to video? She doesn't care, that's fine. Okay, so first thing we'll start Alice's test. The patient's going to lay on their back, please. We're going to put their feet nice, even level, right? It can be any age, and bring their feet up onto the table. And you want them to be just nice together, just like that. You want the heels to be nice and even. And you want to look at the knees from more than one angle. And I suggest you do it this direction and then this direction. In fact, I actually suggest that you do it from this direction. Okay. We're looking for a difference in femur head height, which could be from a number of things. One may be a hip fracture, right? Maybe like a slipped capital femoral epiphysis if it's a younger person. Maybe you just have a difference in your lengths of your tibia or something. Okay? Just give you some ideas. And if the patient doesn't have any complaints or whatever, it's probably just a difference in the lengths. You know, everything that we're doing depends on your patient's history. It'll also give you some idea of what these tests are going to mean. So that's Alice's. The next one is Ortho, and that's done with children. I told you guys to go and look at it on YouTube. How many of you looked at it on YouTube? Okay, so you got an idea of how that works, right?
How many are lying?
How many are lying? Anyway, if you haven't looked at ortolani's, you need to look at it, and then you'll understand it a lot better. And ortolani's is always preceded by what? Barlow's test, right? To try to fully luxate the hip, so that they're sure to get a positive test if it is. Okay, it's not designed to hurt the child, but if there's a weakness in it, they want to know now, so that it can be corrected now, so the kid doesn't have long-term problems. Okay. Okay, next one, we have what? A bunch of contracture tests. So Eli's is going to be face down. And what we're going to do is we're going to, again, always start with the what side? Uninvolved. So we'll just say his left one is uninvolved, and we'll bring this up. And we should be expected to be able to bring this up without any type of problems. What muscle are we stretching here primarily?
Or no, it's rectus femoris.
Right. So then we're going to bring this one up. And as this starts to come up and as this starts to get tighter and tighter, we might get some hunching going on here, right? And that's a hip flexor contracture. The LSS is probably involved more, but that stresses a lot more on the rectus femoris. The other one for the same hip flexor contracture, Thomas is the patient lays on their back. And I want you to put them at the bottom of the table where their knees are just at the edge of the table. And so we'll say that the problem is on which side?
On the left.
Well, it was on the right, so we'll just keep it on the right. So the problem is on his right side, right? So what leg do we want to bring up here? We're going to start on the uninvolved side. We want to bring the right one up, right? Because the left one is not going to be contracted. So we're going to actually bring the involved side up first, but we're not testing the involved side by bringing the involved side. So just remember how to do that. Okay, so we'll have the patient bring this up to your chest, please. And we're going to look to see if this comes up off the table. Okay, it does not. So then we're going to check this one, and we're going to have him bring that up. And when he does that, we're going to look at the back, and we should lose, that arch should go down. If the arch does not go down, you can see how nicely his goes down when he does that. If it doesn't go down, that could indicate that there's a head flexor contracture. If this leg, bring this one up against her. If this one follows this up like this, then that could mean that we have some hip flexor contracture on the right. Or if it comes up and we also get some of this, then we know we not only have the iliopsoas involved, but we also have the rectus femoris. Okay, hip flexor contraction. The next one is the last contracture one we have is what? Obers. And we're looking for a contracture of what? So face your audience over there. We would have him lay on the one side first, on his right side first, right? Because we would test the left one, but we're testing the right one. This is a bad, so we'll just pretend we did that. We don't want Jared to move too much. He doesn't look like he has that capacity. So we're going to bring this up like this, bring this back here, and we're going to have him just lower that down. Okay, he should be able to lower this all the way down to the table, right? And if he can't, then we're gonna say he has some contracture of the IT band, right? Tensor fascia or IT band. But IT band is what the contracture is, they're gonna say. Okay, what's our next test? Patrick's, you all know Patrick's. I just want you to do it in stages. Let me have you lay on your back. And so we're going to say that his right side is bad, so we'll start with the left. You'll go through all the phases. Okay, does this cause you any problem? 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 At any point that the patient says yes, you say what? Oh, yeah. So come up to the good side. Does that hurt you at all, sir? How's this? Oh, no, that doesn't cause him any problems. Does that cause you any problems? How's this? Not so bad, huh? Okay, good. So, but again, we're looking for hip lesion, right? Usually that's like an osteo or something, but it could be anything. And you could do this on a kid. If the kid comes in and they're in a lot of pain, they have a fever, and a lot of pain in that hip, you're thinking what? Infection, right? What is that infection? I can't think of the name of it. What's the infection the kids get in their hip?
No, it's not fever related.
Reactive synovitis. Okay? Right, we talked about that. And so then you'll just bring it up, push it in, right? And so it means, it could be hip lesion, that's fine. It could be, hip lesion, it could be infection, it could be labral tears, a lot of different things, but we know there's a hip lesion. Lesion's a pretty good word to use. Okay, and then is Laguerre's next? You guys know that one. Just stand here, reach down with your superior hand, grab the ankle, bring it up just like this. Don't cause him any problem at any time during that. And he would say yes, and he would say where. Okay, maybe start with a good side first. I can do it. Okay, bring it up, test it. One of the things that you want to do for your boards is you want to look like you know what you're doing. You know? If you don't look like you know what you're doing, but you're doing but you know what you're doing, that's not going to be as good for you as if you look like you know what you're doing and you don't know what you're doing. It's kind of funny, that confidence level needs to come forward. They're looking for somebody who has confidence in what they're doing. So if you say to yourselves, you know, I'm nervous when I take a test, that I can't do this, I don't like to do practicals, and all that, then stop saying that about yourself. Start saying things like, you know, I'm great at taking practicals. You know, I'm not afraid of any of this. This is just a stepping stone to get me where I want to be. There are the kinds of things you need to say to yourself. What's the next one? Scouring. So we're going to use varying degrees. Of course, we would start on the left, but we're going to go right over to this one. We're going to use varying degrees of hip flexion. We're also going to use varying degrees of external and internal rotation as I'm applying an axial compression. And not only am I going to be doing varying degrees of flexion, internal and external rotation, I'm going to also be doing varying degrees of add and abduction. Okay, as I'm just grinding that through there, trying to scour out that pot called the acetabulum, using the head of the femur as my scouring pad. Right? Is everybody see what we're doing? Okay, and that is, again, a hip lesion, a lot of hip lesions, but that one's primarily what? Labral. Labrum. Okay. That's another hip lesion test. What's the next one? Anvil. Anvil. When you're doing that, I just want to make sure that you get the leg into full extension. Okay, I don't want the patient's knee to be flexed. I want it in full extension. Give them a good pop on the heel and see. Could be calcaneal fracture, could be tibial fracture, could be femur fracture. Ask the patient where that hurt. Nellenberg, you're going to see that with a particular gait, right? And this is another one that might be a little confusing. Which side are you going to test and how you're going to have them do that and so on. So let's have the patient stand up. Now, I think you should have them where they can grab onto something. I know we've talked about that. If they had a true Trendelenburg test, what would you see?
Drop.
But before that, when the patient's just watching your office, you would see what?
Smear the hips with the gate.
Trendelenburg gait. Every time that they would pick up that side, if this is the bad side over here on the left, every time they picked up that right one, they would drop and they would walk. Trendelenburg gait. I told you guys you should look that up on YouTube and see how that works. So, if he has a problem, and the problem is on his right side, that's what we're saying, right? So he has weaknesses of these gluteal muscles over here. The first thing we're gonna have him do is post up on which leg? The left leg, and we're gonna have him pick this up. And I don't want you to hold on, okay? But you're gonna stand there. So I'm gonna ask you to just bend it for me. Bend your knee, there you go. And that should be fine. The weakness is over here, so I'm gonna have you put that down. And his abductors, so when he raises up, this should lower, it'll do something like that, okay, if he has a weakness. Because there's no weakness on the abductors on that. Okay, remember, it's the side that he stands on is the side of the test. What's our next test?
Craig's test.
Craig's test. I'm going to have you lay face down. That's for anteversion and retroversion, right? And you know that's a torsion that takes place in the femur, right? So you'll be able to see that. Retroversion causes the toeing in. I'm sorry, anteversion causes the toeing in, retroversion causes the toeing out, right? And when they line them up just right, then that causes a lot of problems in the acetabulum. So you want to see that. So what you're going to do, problem is on the patient's right side. So remember, when you're taking your patient prone, supine, and all that, it's a little bit difficult. So just remember what side you're dealing with. So we're going to bring his leg up. We're going to palpate the greater trochanter. We're going to put his greater trochanter, make it parallel to the floor. Once you feel that it's parallel to the floor, we're going to drop a plumb line from the ceiling. That plumb line is going to intersect down here at the medial portion of the knee, and we're going to measure this angle. Does everybody know what angle we're measuring? Any questions on this? Some people seem to be a little confused on that. And so we're looking for what, 12 to 25 angle, less than, is that right? 12 to 25, yeah. Less than 12 would be retroversion, right? Greater than 25 in anteversion.
Will you want us to do that? So should we bring a goniometer or something?
Yeah, you just show me just what I just did.
Oh, okay.
And you just say the indicators, if it's greater than 25 or less than 12. Less than 12 would be retroversion, greater than 25 anteversion.
Q angle.
Q angle. I probably will not have you do that, but Q angle is something you always want to check for what? What are we looking for? Probably some problem with what? The hip? No, down here at the knee, right? Patellofemoral arthralgia, maybe some leading to like chondromalacia patella, where that patella has just been rubbing wrong, causing that little ulceration underneath there in that cartilage. And so you'll check that Q angle from the ASIS down to the patella, and then from the tibial tubercle up, and you'll measure that angle. There's different ways they do it, but if you just measure that angle, I think that would be absolutely sufficient. And I just want you to basically remember who has a wider Q angle, greater Q angle generally. Generally females do. Okay, and which one of the main rectus femoris muscles is involved with maintaining the patella in its track? The VMO, right? That's this medialis obliquus. Okay? What's our next thing?
Valgus stress.
Valgus stress on the knee. I'm going to have the patient lay on the back. You can do it seated. You can do it laying down, however you want to do it. In fact, yeah, this is cool. Now, lay down. Sit up. Come on over.
Roll over.
There you go. Yes, roll over. So his problem is on the right side. Okay, so we'll valgus stress. We'll start on the left one, bring it up. I'm not sure where you can see better. If you need to move, feel free to do that. We're just going to take the knee into full extension. We're going to add valgus stress by moving his ankle lateralward and with the fulcrum in the lateral side of the knee. Then, if that doesn't cause any instability, we're going to then bend the knee a little bit and do the same test. Remember how we did that with the elbow. So we'll go over to this one. Same thing. Keep it nice and straight. And I like to do it like this, but that's okay here. If you just do it like this is sufficient, and you can bend this like this. Okay? We're looking for not just pain, but instability. So with these instability tests, I want you to say, well, you know, I have increased movement, abnormal movement, something like that. And the other one, of course, is the opposite.